in real life.
All right. So as I discussed, in 2020, total spending on Vermonters, that's across Medicare, Medicaid, commercial, et cetera, even out-of-pocket costs, was about 6.4 billion. And like I said, I estimate it's probably over 8 billion today. I look forward to seeing what that number is, if I'm correct. But that's what I'm guessing it probably would be at, given the growth trends. But nonetheless, I do think that the split between commercial, Medicare, and Medicaid is probably still within this ballpark. So about 27% of the spending in Vermont, on behalf of Vermont residents, is the Medicaid. And just for context, again, we have an $8.5 billion budget, a state budget. 2.3 billion of that is Medicaid. And, total human services is 3 billion, but 2.3 billion of that is Medicaid. That's services that go through Medicaid, which is the second highest spending after K-12 education. So as I just said, Medicaid expenditures are about 2.3 billion gross. And again, gross is all funds, state fund, general fund, special fund, federal funds. Medicaid is funded through a combination of state and federal matching dollars. I'll get into this thing called FMAP in a moment, but this is federal participation accounts for 62% of the overall Medicaid spending in Vermont. This isn't just our matching dollar. This is also things like federal grants and other stuff. So you can see that a big chunk of our Medicaid budget is federal dollars. Not all of our federal funds for the state program come through this thing called FMAP. You're gonna hear a lot about FMAP this session. It stands for Federal Medical Assistance Percentage. And what that is basically is in our Medicaid program is the share of state Medicaid benefit costs that are paid by the federal government. Our FMAP is calculated based on a 3-year average of state per capita personal income compared to the national average. That sounds complicated, but basically every state gets federal matching dollars. It's based on this formula that the federal government uses to determine how much each state will get for this match. And the base part of this formula, or the easiest way to describe the parts of this formula, is that they look at the state per capita income compared to the national average and over a 3-year period. So if our FMAP, which is our federal share, goes up, it means that we get more federal match for our dollars and it costs less these dollars to do it. But it also might mean that our per capita income has gone down. So it's sort of a double-edged sword. Like if the FMAP goes up, it means the federal government is providing a little bit more assistance in the share of our Medicaid, but it might be indicative of underlying problems in our per capita income relative to the rest of the country. So when we see our FMAP go down and it costs the state a little bit more money to provide the exact same service, we're always bummed out about that because it impacts our state budget negatively. But it could be an indication that per capita income is actually getting better. So something to think about.
The good news and the bad news.
Yes. There's good news and bad news with all of this. So no state can receive more than a 50% match, more than 83% match and less than 50%. The states that are getting 50% match are usually the states that have the highest per capita income. Those are your California, New York, Connecticut, New Jersey's. Those are the ones that are just kind of hitting the max and they're just not going down.
Wyoming is the one that stands out.
Yeah, I think that's because they have a lot of natural resource revenue.
True. Yeah.
So when you look at their per capita income, it's a rural state when you look at their per capita income because of the natural resources industry.
Okay. We don't have them.
You think that a lot of people fall there too.
No one wants granite anymore.
Well, pretty soon we'll be selling our water.
That's assuming we don't go back into drought like we were several years ago.
So the states that have the highest FMAP tend to be the states that have the lowest per capita income. And that's Mississippi has the lowest, the highest FMAP because it has very low per capita income relative to the other states. And then just I threw in the other New England states just so you get a sense of how we fare. So Connecticut, New Hampshire, Massachusetts are all at 50%. Rhode Island's at 57.5%. We're at 59%, and Maine's 61%. States also receive what's called enhanced FMAP. And that might be for different things. So most of our federal matching is this sort of 40-60 match, which I'll get into the specific numbers in a moment. But we have some things, some programs for which we get enhanced FMAP. For instance, we had an expansion population under the Affordable Care Act. These were the folks who came off Catamount or VHAB that were childless adults and didn't fit into the categories that Medicaid existed prior. This expansion population, the federal government is giving us 90-10 match on that particular group. And the reason is because when the Affordable Care Act passed, in a lot of other states, this group was just uncovered. And when they expanded Medicaid under the Affordable Care Act, the federal government wanted to help some of these states that were less generous than Vermont or Mississippi's and West Virginia's and Alabama's, but they also recognize like we're forcing them to cover these people, but they don't necessarily have the general fund to do it or have a plan for it. For the first couple of years, they were getting 100% federal dollars from that group, whereas we were getting like 81 for this group. And so, but the way they did it over time, it took about 5 or 7 years, theirs went from 100% to 99% to 98%. We went from 80%. And then we sort of all met in the middle at 90-10 for this particular group. There's about 40,000 Vermonters that are in that group. Now, those folks, all they know is that they have Medicaid, a Green Care card, whatever. But for us, and that they have coverage, whereas they might not have prior to the Affordable Care Act. But for us, it's important because behind the scenes, how we are able to pay for them helps us provide that service. So another group. So this is just a visual of that. So our federal or FMAP for this particular going into 26, when you see the budget presented to you, this is our current FMAP. It's 58.81%, which means that in the state share is 41.2%. But translated, that means for every dollar, for every general fund or state dollar that we spend on Medicaid, we're getting $1.43 in federal match, which grosses up to $2.43. So in short, for every state dollar spent on Medicaid, we're getting $2.43 in service. It cuts both ways. When we cut a dollar from the Medicaid program, we lose $2.43 in services. So when in the past, when we've been in tougher times and they've been looking to the Medicaid program to cut, well, we might have saved $1 million if we cut $1 million out of Medicaid, but we're losing $2.4 million in services. The other program that gets enhanced FMAP is our Children's Health Insurance Program. This is about 4,000 kids. This is a smaller group. That's almost 70-30 match. So then for every dollar we spend, we're getting $3.47 in services. And then for this childless adult group, which is this expansion population under the Affordable Care Act, for every dollar we spend, we're getting $10. So you can understand, you can see how important our federal match is to our system. Which when we go back to talking about global commitments and being able to want to cover more services, this idea that like the more services that we may be providing or would like to provide, we can capture them within our waiver, we now can get federal match for those. So instead of a program, if we really want to provide this program to this particular group, if it would, let's say, cost $1 million, we would have to lay out $1 million in general fund. But if it fits within the scope of global commitment and within our caps and within terms and conditions and all these things, and get permission from the federal government, well, now that program only costs us $400,000 and the federal government pick up $600,000. Just to give you a sense of why we've done this. Now, of course, we don't just want to throw everything under the sun under our global commitment waiver, because we still have to buy $400,000 to provide the service. And the federal government will be like, no, that violates your budget neutrality. So this gets into the complications of why we have our global commitment, but also what it does. And again, if you see one Medicaid program, you see one Medicaid program. But
Well, we asked a question, this would be impossible to answer, but, and to quantify, but when you cut Medicaid and you end up actually cutting more than what you're cutting,
Could I be?
how does, how does that, what are the downstream effects? Like, how does that affect the health of the state, or how do people pay for that? They don't, so they go, they become uninsured, or they
the state
don't
cuts the
get
service, it
treatment.
cuts an eligibility. If there's no support system in the community, it would just go without, I suppose.
Okay.
I'm gonna ask a question that might relate, but go ahead.
Oh, no, that's fine. I was just gonna ask to be excused for a moment.
Oh, no, please go right ahead.
Oh,
Yeah.
my wife just had an $850 card bill and I need to go pay it.
Okay,
So I'll be right back.
okay. My question was, we're talking about the money here, and it relates to what you're asking. So, but we're also talking about patients. We're talking about people who have different kinds of conditions that might place them in a childless new adult category. They might have a chronic illness or something, but can you categorize the people, or the kids, or the adults in each of these groups, or is this something that we should be asking of DEVA and AHS when they come in, or?
Are you asking about the eligibility for these groups?
Yeah,
What are you
well,
asking?
what their physical medical condition is that places them here. I mean,
So
obviously.
Medicaid, it's a combination.
Income, but there also are folks who might be in Medicaid and have a low income because they can't work.
Yeah, so those would often be our aging, blind, disabled.
Yes.
Who have a disability that qualifies them along with their income, or sometimes the income doesn't matter for some of those groups. I would defer that to Ashley.
Oh, good. So Ashley will be here.
My hopes, so I
Is it
invited her.
tomorrow? We're hoping.
So I invited her. I didn't remember that I had this one on the agenda. It was on my calendar, but when I talked to her.
Yeah,
So anyway, I asked her if she's available for tomorrow. Hopefully she is. I emailed her. We'll find out if she is. It was kind of last minute, so I hope she is.
he's reached out to her.
I emailed her. So what I'll say is that having Ashley in the conversation always enriches it, because she can bring a level of depth into the catacombs of Medicaid that she lives and I do not,
And the rules.
and the
And
rules.
the rules.
And
That we just went through.
the weeds around global commitment, and she helps negotiate it, so she can tell you the different pieces.
Okay, we need that.
Yeah. So that's Medicaid and I'll get into more, we'll go into more details tomorrow. And then this is sort of actually coming to the end of this.
Cool.
Wow.
So, yeah, I thought this would take a lot longer, but you didn't ask as many questions as I.
Well, I think what we might do is.
No, bad. Don't really.
I tried.
We might go back. We
Totally can.
Take
We
the
have
time to do
questions.
that. Yeah.
And then I just sort of touched upon the regulators, right? So you have Department of Financial Regulations, which finance has jurisdiction over, but their big piece in the system is looking at solvency of insurers, et cetera. And that's an important subject. We have the Green Mountain Care Board. They do rate review for hospitals, and they do rate review for the insurance company for health insurance. And they're also an important part of the healthcare reform efforts of Vermont. And they also are the data people who have all the data for this stuff. So you'll be hearing from them. Then you have like Attorney General, which looks at Medicaid fraud. You have the health department, which does inspections. They're part of the health system, right? And then I've given CMS, Center for Medicare and Medicaid Services, because they're the ones who we have to work with in order to get permission to do things within our Medicaid our federal program. And then these are just other stuff. So, again, just a quick note about the Green Mountain Care Board, just to set the stage. They were created in 2011 when the legislature did Act 48. Act 48, for those who, everybody, it's too weird, was the bill that tried to create a universal and unified healthcare system. at the time there was supposed to be a board that oversaw it all. Pre-med care board is sort of a remnant of that, not remnant, but it was also a time when they rethought about how do you want to regulate hospitals and insurance companies. And Senator Cummings was earlier talking about how it used to be under this organization called FSHCA, and before that it was the Healthcare Authority. And yeah, so then GFR was created and the Pre-Med Care Board were split. So Pre-Med Care Board is the current organization. It's actually a board. It's a 5-member board who are appointed by the governor for 6-year terms. They're sort of cycled terms every year. There's a new person who's in and out. There's a whole nominating process for how to get on there. And then they have a staff of, they must have 20 to 30 people who work on it. So it's not just 5 people who sit around making decisions. They've got a whole organization behind them that works on this. They regulate health insurance rates, hospitals. They do this. They regulate these things called accountable care organizations. Which is actually will be going away relatively soon, so I won't spend too much time on them. And then other things, major capital expenditures, which you were just talking about, certificate of need, maybe certificate of need. They also support a lot of innovations. They're one of the signatories for this current thing called the Vermont all-payer model, which is sort of a transformation approach to moves into global budgeting, et cetera. Again, I don't want to get into the weeds. There's current discussion about a new model called the HEAD model. I'm not going to get into it, but they would have to be a signatory on that. So along with the governor and the Agency of Human Services, the point I'm trying to make is that they're integral or part of the center of Vermont's efforts, along with the governor's office and the Agency of Human Services in our healthcare reform efforts. And then they also are like, they do the data and analytics. They house this thing called BCures. I know what that acronym stands for. It's long and unnecessary.
Clinical growth, care, utilization.
Yeah.
And something.
But anyway, it's a source of where we get a lot of our information about health spending. It's sort of all payer database, all claims database.
Yeah.
Most payers, not all payers, report their data to this database, and it's a dearth of useful spending information. All the data that we get, most of it comes from there.
So just, it might be helpful. We are going to have the board come in. They couldn't come in that week, coming in next week. But it might be helpful just to click on that link that Nolan has for the statutory purpose. And then remember that it was created in 2011 under Act 48. And for us, it was really created with the notion of having a single payer system. And we've changed a lot since then in terms of where we're going with healthcare reform. So it would be helpful for you to look at that, and we'll probably see we'll have discussion about should we or should we not be making changes, and then how do those changes relate and all that in here. There will be bills related. So
That's great.
and the Act 167 work will also affect the board. So there's a lot here, big time. I can't apologize for it. It is complicated things.
That's our job.
Yeah. And there was another thing I was going to say. Probably the biggest one.
Yeah, so this is the purpose of the board,
Yeah.
the statute.
Yeah. You all know how to get to the statutes online and do that, right? All that.
Oh, yeah.
And then my last slide is just the federal poverty
There we
level.
go.
This is just a reference.
Oh,
They tend to be released late January, early February. So as soon as I get new ones, you will have the new ones. And we can decorate the wall with even more deal charts. And that's all I have in my presentation, but I'm open if you have more questions. Or we can just end early. It's all.
let's do this for a couple minutes. Why don't we, I know I've got it right here, but are there specific areas that you might like Nolan to repeat doesn't hurt to have repetition, just a little bit. Maybe, the distinction between the global commitment waiver, FMAP, just those general distinctions. Would that help people? What, is there anything that you'd like to hear about or ask questions about before we finish? This is what we were gonna do today, so you know, if you have questions, this is a good time to.
It's a lot of information, you know,
It is a lot, and yeah,
and a lot of this is stuff that some of it's stuff that everybody knows, and some of it's stuff that people know from their professional lives as well. But I just wanted to try to get it all in one place and try to level set a little and just create a background.
okay, well, this is good, and just so you know, when we get bills in here, there will be bills referred here that have insurance issues that relate to payment. That will also walk down the hallway to finance, and finance will be getting bills in that I might, and Senator Cummings and I might want to have health and welfare look at. And ultimately, it spends a lot of time. These things go right to appropriations. So our decisions in here really relate to the policy and what makes sense for helping the people who need the safety net. Do we recommend raising the eligibility cap and temple poverty level? Do we recommend putting some more money into community services? All that stuff just falls right here. And we work closely with our peers in finance and appropriations.
Community services. You might tell people what those are.
Yes, and we're gonna have them in, but the designated agencies, the SSAs, the
Now,
special services.
you speak in Greek.
Designated agencies are things like Howard Center or the Washington County Mental Health Center.
What I work for,
What you work for.
What do you work for?
Lamar County Mental Health as a designated agency.
Yeah, and those, and we'll have AHS in to talk tomorrow. After we hear again from Nolan. Nolan's coming back in, so my suggestion, homework for tomorrow is to go through Nolan's presentation. Again, look at it and see how much is there. It's amazing, it's really terrific, and thank you, Nolan. Gets better every time. It's really good. And then bring your questions in. And then we'll go through this again, and we'll have someone from AHS, hopefully Ashley Berliner will be here, able to answer other detailed questions.
Oh, do you have that online so we could download
It should be in the documents.
It is.
It's also on the.
It is. I've been looking at it. Yeah, it's with our, if you go to our webpage, and then you go to,
It's very simple. I
under
can help you.
the date, and under the date, you'll see the witnesses.
Yeah.
And then you can click on him because he's our witness.
Whole thing is this.
Anything else? And remember that the area of our jurisdiction represents a significant amount of the big bill. Over, like 20-something% of the appropriations. So when we make a policy recommendation, it has an effect. And that is one reason why we work so closely with appropriations and with finance, because you have to raise the money to cover it. And you have to have the money to spend. So we can't just make decisions categorically. We can do that because we think it's important. We need to be very much aware of the financial and the fiscal responsibility that is associated with it. Let's see if there's something else I was going to say, but I always forgot. It'll come back. So we are good.
And some of the stuff that's in here will be repeated in more depth tomorrow,
Yeah,
the Medicaid stuff. And then again, we're doing health insurance 101, I think on Friday.
Yeah.
Some of it again will be repeated. So you can see a lot of these charts over and over and over again because it's context into which rabbit hole we're going to go down.
Yeah, and yes, and there are a lot of advocates who are very interested in everything that we've looked at. And then we have the healthcare advocate who is responsible for bringing us patient healthcare, citizen information. What else? All together, it's really exciting what we do, and having the expertise that we have sitting at the end of the table.
Hmm.
Okay, so we're going to go off live. We'll take a minute to talk about some before we go off live, I would entertain a motion to nominate clerk. And I know that you are each clerks in other committees. It doesn't hurt to have redundancy.
I'm willing to do
I will nominate a clerk for her committee. I will nominate Senator Samuel Douglas.
I'll second that.
Oh, are you smart? All right, so discussion? No? Do you accept the nomination?
one.
All right, so I will call the roll this time. All those in favor of Senator Douglas being our clerk, both say aye.
Aye.
Opposed?
Sorry.
Good, thank you. That's great. And we'll go through the clerk's responsibilities, and Senator Gulick is an old hand at it, so she can help with that. All right.
It's a low bar as well.
Yeah, that's exactly right. You're gonna be great.